Good afternoon. First of all, thank you very much for the invitation. It's always a great pleasure to be autumn in New York, and actually it's even cold, actually warmer than in my town. So having said that, we'll move to my presentation, and I will try to touch a few arguments. And here, I guess, first of all, we are talking about ineligible patient. Second, the issue is which is the best possible treatment regimen for those patients. And now that we have many options, 2, 3, or 4 drugs. I would like to start with 3 very important messages. Beside the choice of the combination we are using, something is essential in the treatment of myeloma. First is early intervention, because myeloma is an accumulation of genetic mutation that with time is making the disease more and more resistant. So early we treat it, more intense we treat it early, better is the outcome. You can see clearly from this slide that 5-year progression-free survival is now around 67% in patient treated with dose-intense regimen. Is few months after 4 to 5 relapse. So you can imagine here the first issue is to treat it as early as possible, as more intense as possible. Then there is other 3 issues. And the 3 issue is risk. Myeloma is not one disease, it's basically at least 3 diseases. We do not have the biomarker to differentiate it beside the chromosomal abnormalities, but basically there is a very good risk. If you want, with a less genetic instability and more ability to maintain a given status, and we have in the middle, the vast majority, the standard risk, and the very high-risk population that is around 15% of the total population. But the point is, a dose-intense treatment, the new agent have been mainly improving this year the outcome of good-risk patients. We have been not that good in high-risk patients. We have been very effective in a good-risk patient. And therefore, a good treatment in good-risk patient may probably even achieve cure today. The other issue is the CR. CR is important. CR is predicting good outcome, no question. We have probably more than 5, 6 studies all showing the same issue. But here the point is not to achieve CR in any patient, because if I'm facing a resistant disease, maybe I'm not achieving CR. But certainly, if I have treatment A that is giving me 50% CR, and treatment B that is giving me 20% CR, I should choose treatment A, because I'm giving more opportunity to my patient to achieve CR and therefore to benefit of a better outcome. The last issue is continuous therapy. Continuous therapy has been shown, meta-analysis in several studies, clearly improving not only progression-free survival, but also overall survival. So these are, in my opinion, very important concepts: early intervention, no risk stratification, increase CR as much as possible, and continuous treatment to maximize our benefit. This is the curve and why these concepts are relevant. Because basically we never achieve eradication in myeloma, and therefore both CR and continuous treatment are quite essential. Now the question is 4, 3, 2, 1. Well, let's start with 4 drugs. My first statement is today 4 drugs are not showing any additional benefit with current available treatment. Proteasome inhibitors, basically, and IMiDs. And you can see it here. This is a study that has been performed many years ago. It was a 4-drug versus 3-drug, but in one arm there was a maintenance, and the other one there was no maintenance, and basically the only advantage that was coming from this 4-drug study plus maintenance was basically mainly coming from the presence of a continuous therapy. Then we have other 2 studies, and basically this is a Mayo studies, bortezomib, dexamethasone, cyclophosphamide, lenalidomide in comparison with bortezomib cyclo or bortezomib lenalidomide. No difference. Why? Because the moment we put 4 drugs together, we do increase so much the hematologic toxicity that we lose the potential benefit of the 4 drug. So potentially, the 4 drugs have a value, but since today we are increasing too much hematologic toxicity, this is not really translated in clinical benefit. This is another study coming from Austria. This is basically the same paradigm, bortezomib thalidomide, cyclo, dex. Once again, too much cumulative toxicity here from a peripheral neuropathy point of view, but at the end of the day, no major benefit. So the future might be for drug. It's not today, we do not know, but the future might be for drug, because certainly today, the introduction of monoclonal antibodies with toxicity that are not cross-present in other compounds will probably make a 4-drug R-CHOP. We hope to have R-CHOP for myeloma. Maybe we will achieve it. The 4-drug combination is in the future for monoclonal antibodies. You can see here the combination that are currently under evaluation. These are all CD38 monoclonal antibodies, combination bortezomib, thalidomide, bortezomib, alkylating agent, melphalan, or cyclophosphamide. Now, if 4-drug is not the standard for the transplant-ineligible, 3-drug is, but 3-drug is for the fit patient. And then we'll see later on the differentiation in a good clinical condition. Which are the major 3-drug combination available? Basically, and I'm sorry here, there is a lot of our European taste or European availability of drug that is also quite important. Basically, there is a combination of bortezomib plus chemo, cyclophosphamide from one side, doxorubicin from the other side. Do not forget, in extramedullary disease, this is a value compound. When we start to face extramedullary disease, doxorubicin is something to take in consideration. On the other side, you have certainly bortezomib thalidomide and bortezomib lenalidomide, combination of proteasome and IMiDs. Lenalidomide certainly better than thalidomide, more effective, less peripheral neuropathy, of course, more expensive. Here is some slide of the study. VMP is what we have in Europe and our standard of care for the combination with bortezomib. Certainly VRD doesn't have a phase 3 study, but is a major standard for, and probably the best available today, combination putting together the proteasome inhibitor plus the IMiDs. On the other hand, as we were saying before, bortezomib and cyclophosphamide might do represent an alternative, a cheaper alternative to the combination bortezomib and lenalidomide with similar efficacy, although lower proportion of CR rate. Now, coming to the new generation, of course, we have a second generation IMiD such as lenalidomide. We now start to have a second generation proteasome inhibitor such as carfilzomib, and certainly carfilzomib is adding to VRD. Certainly is probably too strong. to give you an idea, you can see from this study that while you might go bortezomib plus alkylating around 30% CR, bortezomib plus lenalidomide, you might reach 50% CR. Carfilzomib plus lenalidomide, you might reach 70% CR. So you can see here from those three different opportunities an increase of CR rate of around 15–20% moving from one combination to the other. Of course, cyclo is another combo for carfilzomib, and if you want the same paradigm we just saw before for bortezomib. Last but not least, Ixazomib. Ixazomib is under evaluation today in the combination with lenalidomide, advantage of an oral proteasome inhibitor. This will be the major advantage of this compound. Similarly, efficacy to bortezomib, certainly a major advantage from an oral administration of a proteasome inhibitor. Now that we have said all this, which could be the conclusion? Probably no major difference between the different combinations. If feasible, proteasome plus IMiD is certainly the best in town. If we have some concern of cost, proteasome inhibitors and cyclophosphamide may represent an alternative. Now, the frail patient. The frail patient do represent even 40% of the total myeloma population. Do not underestimate is today and will be in the future even more relevant, the most relevant myeloma population that we see in our offices. And I think it's very important to define a few issues. First, age. It's not 75 years of age that made someone frail, it's 80. Provided there are no additional comorbidities. We were, until now, in our studies, make a cutoff of 75 without the evaluation of comorbidities. Without comorbidities, the frailty comes at 80 years of age. Younger, of course, if presence of comorbidities. And here are the four major parameters to evaluate for the definition of frailty. Age, as we were saying, comorbidities, as we sometimes do for transplant, we don't do for elderly population, cognitive condition and physical condition. So basically brain and leg that is becoming a relevant issue in an aging population. Under this condition, the two-drug combination is probably the best. Today, we have certainly lenalidomide and dexamethasone that is quite feasible, friendly approach, effective. You can see here from this study, once again, how the continuous therapy was important. The curves are diverging at 18 months when you stop treatment in the other two arms. And what is also important to evaluate, that the time to next therapy is approximately 3 years. So the continuous therapy allows you to keep going, although the M protein might be increasing, but slowly, keep going and gain another 9 to 10 months versus the typical definition of the progression-free survival. Why I'm saying two drugs? I'm saying two drugs because also pioneered by Dr. Niziski at Cornell, there was a study when we started to evaluate this combination in a community-based hospital patient population. Usually trials are very selective in terms of inclusion and exclusion criteria. In my clinic, almost 35% of patients are unable to enter a clinical trial for inclusion and exclusion criteria. Unfortunately, the day after, we have the same drug in our shelf, we give it to the other 35% of those patients, the one that has been excluded in clinical trials. But to make a long story short, the moment we run, and these are 3 independent studies, we run a randomized study combining 2 drug versus 3 drug combination without major exclusion criteria that are usually present in the clinical trial. You can see here that the difference between 2 and 3 drug is not so important. So the conclusion is, certainly in patients with frailty, with comorbidities, with more than 80 years of age, the 2 drug combination is certainly not damaging, but the 3 drug combination is not giving any additional benefit. We currently also, because LEN is one, but Ixazomib, the oral proteasome inhibitor, will be the other one, oral compound, there are ongoing studies evaluating the same type of approach, the 2 drug combination versus a 3 drug combination with, once again, from Europe, mainly alkylating agent. So which is my conclusion? The conclusion is, beside early, increase CR as much as we can and give a continuous therapy, the 3 drug combination is today what should be used for the fit patient. Then today you can basically define 2 3 drug combination, proteasome plus alkylating from one side, proteasome inhibitor plus IMiD on the other side, slightly better than the previous, followed by a continuous therapy. We do not know yet if 2 years of until progression. Studies are ongoing to evaluate the duration of maintenance after induction. For the frail patient, the same concept. We just take out 1 drug, we go back to the 2 drug combination, and once again, the continuous is an important factor. I will close with this slide saying that we learn from transplant people to give an induction and then to consolidate. We should do sometimes the same in elderly population. When we are in a gray zone, I don't know if I should use 2 or 3. We do like to start with 2 because also the majority of toxicity are in the first 3 to 4 courses. So we might start with the concept of 2 drugs for 3 to 4 courses. Then is badly tolerated, I'm keep going with 2. Is very well tolerated, but my efficacy is not enough, I'm consolidating with a 3rd. But the last concept is also that after 1 year of treatment, we need to go to a maintenance approach, and therefore, RD, for example, is better to use it at 10 than 25. So we need to have those 3 concepts. We might have a gentle induction, we might consolidate later on, and we might have a continuous therapy with a low-dose intense approach to keep patient on therapy for the required time. This was the last one. I hope I'm in time. Thank you very much for the attention.